Chintan sir. So good afternoon, everybody. This is such an elite congregation of experts so passionate about uh, treating or taking care of a person with diabetes. I have a huge pair of shoes to fill up today, and I'm going to give you my perspective using somebody else's slides on the use of GLP-1 for renal protection in a person with diabetes. So we all understand that GLP-1's analogs are some very potent and efficacious molecules to be used in a person for management of diabetes. We may or may not be using it because of either cost issues or because it is an injectable. We now also have oral GLP-1s. How is it used? Its role is to stimulate the insulin secretion. It will also suppress the glucagon. It will slow the gastric emptying and take care of the appetite. Now, as a diabetic, whenever I am seeing a person with diabetes, my first concern is to take care of the hyperglycemia. The first thing that a patient with diabetes or a person with diabetes will expect from me is to take care of the numbers, to take care of the sugars. Ultimately, by taking care of that hyperglycemic state, maybe using any molecule, I am able to give some sort of a protection or delay the onset of diabetic kidney disease. The therapeutic role of this molecule per se, uh, if I have to initiate a molecule which is efficacious in terms of the entire cardiorenal continuum, there is a lot of evidence which I'll take you through for the use of GLP-1. It is going to improve the glycemic control, and I'm sure that all of us are on the same grounds when we talk about it. And it also is going to promote the weight loss. There are n number of GLP-1s in the market right now, starting from Dula, Sema, liraglutide, the three very popular ones in the Indian market. And how are they going to give us the renal protection? There are some direct effects on the kidney by reducing the albuminuria and reducing the proteinuria. It is going to enhance the natriuresis and the diuresis. It is going to reduce the inflammation that the entire discussion for the previous speaker was all about and the oxidative stress. It also has some systemic benefits. By improving the glycemic control, it is reducing the glucose mediated kidney damage. It is also having a pleiotropic benefit of lowering the blood pressure, reducing the weight, and alleviating the kidney strain. It has some anti-inflammatory and anti-fibrotic effect, which were the last words of the last session, and thereby it modulates the renal inflammatory pathways. Beyond diabetes, GLP-1 have their impact on the brain, on the gut, on the liver, on the heart, on the inflammatory axis, on the gastric emptying, and you can look at all the plethora of the systems where GLP-1 have their beyond diabetes or pleiotropic benefits. Now, when I, as a diabetic, again, I'm looking at a person with diabetic kidney disease, I look at it as a clinical syndrome. It's not just the sugars. I have to also take care of the decline in EGFR. I'll also look at the proteinuria. I'll also take care of the blood pressure and also screen, diagnose, and take care of the person in terms of the CV status. It is not a singular, one direct, unifocal approach. When we talk about people with diabetes, for type 1, 3 out of 10 people with type 1 diabetes will have CKD. 4 out of 10 with type 2 diabetes will have CKD. And diabetes is the cause for approximately half of the people with end stage kidney disease. That is why, again, the importance of use of a molecule which has a cardio-renal protective impact along with a glycemic impact. We are moving from just a glycemic protection or just a glucocentric approach to a cardiovascular adipocentric approach. And that is where the role of GLPs are coming in. CKD, we also understand, is going to amplify the CV risk. And people with diabetic kidney disease, as ma'am just said, there are so many people with dialysis. They are having mortality not because of CKD alone, but because of the CV fatality as well. So again, the previous speaker just talked about the 4 pillars for management of a person with type 2 diabetes and CKD. SGLT2, the RAS blockade molecules, the non-steroidal MRA, and the GLP-1 RAs, along with SGLT2s. That SGLT2 will be the topic for my opponent to speak about. But let's look at this chart. For again a physician or a diabetic or an endocrino, when we have to choose a molecule, we have to choose a molecule which has all of these benefits. You cannot again be unifocal and only talking about the glucocentric approach. Let us talk about the benefit in terms of reducing or delaying the progression of CKD. We talk about benefit of ASCVD, benefit in heart failure, benefit in the hypoglycemic risk as well. And we talk about the weight benefit and cost as well. Now, GLP is scoring everywhere except for the cost column. Let's look at the evidences. Across different recommendation guidelines, the prescription or the recommendation of GLP-1 in terms of the EGFR levels, if you see, the prescription of GLP-1 being safer till the EGFR of 15. After that, again, it is on the discretion of a physician. You may or may not prescribe that. Again, there are a lot of clinical trials going on prescription and recommendation and the usage of GLP-1 in people with diabetes and dialysis. All of these recommendations, if you see, this is a summary of all of these recommendations where they are saying that they are one of the most potent molecules in terms of the glucose benefits, but they are also potent in terms of delaying the onset of CKD, in also taking care of the ASCVD, the atherosclerotic cardiovascular benefits, and they are also recommended in people with kidney or renal transplant. They can be used in people with dialysis to avoid hypoglycemia. Again, GLP-1s being potent in reducing the hypoglycemic events. They are although contraindicated in people with medullary thyroid carcinoma or men too. Let me just take you through a summary of all the clinical trials wherein GLP-1 have shown benefit on the renal status. The lixisenatide, the Alexa trial, wherein it has showed reduced progression of the urine albumin creatinine ratio. The leader trial for liraglutide and the sustain 6 trial for semaglutide, where both of them have demonstrated reduced risk of CKD development and progression, and they have benefited in reducing the onset of albuminuria, macroalbuminuria. The Award 7 trial with dulaglutide also showed superior renal outcomes in people with diabetes in comparison to insulin glargine. Now, insulin being one of the most widely used molecule in people with diabetes. And the guidelines now also recommend that whenever you're choosing an injectable, do consider initiating with an injectable of GLP-1. Again, it's your choice. There has been a meta-analysis of 7 CVOT trials of more than 56,000 people, and the analysis showed that GLP-1 have reduced the composite risk of adverse renal outcomes by 17%, and this is not a small number. The Rewind trial of dulaglutide has shown protective effects on the CKD people. The Fountain trial was again an analysis of all the GLP-1s, the liraglutide and semaglutide, and has shown benefits in the CKD stages. The Flow trial, give me just 2 minutes. The Flow trial, again, a very pivotal study on the use of semaglutide and renal outcomes in people with type 2 diabetes and CKD, and it has shown benefits of the usage of GLP-1. Now, how do we summarize all of these trials? These are all important trials, landmark trials, showing us that GLP-1s are important. How do we understand or what is our take home from that? That, of course, GLP-1 RAs are beneficial. They are renoprotective. Please don't shy away from using them. And like there is an inertia on using insulin as an injectable for people with type 2 diabetes, there is an inertia in using GLP-1s as an injectable in people with type 2 diabetes. Let me just take you through this latest slide of the Sustain 6, which has shown that semaglutide, one of the most potent and the most talked about GLP-1 currently across the globe, it has shown 36% risk reduction in terms of the secondary outcomes, which was an event driven in macroalbuminuria, doubling of the serum creatinine, end-stage renal disorders, or renal death. With that, I almost come to my summary slides. That diabetic kidney disease, we all agree, and that is why the interest group is over here, leading the task on prevention of diabetic kidney disease and taking care of people with diabetes. GLP-1 has a lot of benefits in terms of delaying the onset or dealing the progression from stage 1 CKD to the following stages. It has a beneficial effect on the entire cardiorenal continuum, and it has shown reduction in albuminuria and their ability to reduce the progression to end-stage kidney disease. There are a lot of clinical evidences. We've seen all of those trials wherein GLP-1 have proven their merit, and they have a great promise in preventing the onset as well as progression of diabetic kidney disease. With that, this is my last slide because this is a debate, and sir, there was this comparison between the use of SGLT2 and GLP-1. As a person, somebody who is prescribing both, I think the take-home message for the audience is that for early stage CKD, SGLT2s are useful, are beneficial. For effective reduction in albuminuria, especially in advanced CKD, GLP-1s are efficacious. With that, thank you all for your patient listening.
Now I would like to invite Dr. Amit Gupta, who is going to talk regarding SGLT2 inhibitors for
So,
renal protection.
yes, thank you, sir. First of all, Dhruvi, thank you very much because I just told Dhruvi 15 minutes before that Dr. Surinder Vittal is not here. Can you take the topic? And she very humbly agreed, and she has done a great job. And we decided that we are not going to have a debate. We will simply present the topic. And the another debater, Dr. Kaushik Biswas, again, he is sick, so he could not attend the meeting. So I am stepping in to take his part of the debate. Uh, Already a lot of this has already been discussed, and to inform this group, Diabetes India is launching an initiative today, and just a few minutes after this there is going to be a press conference in which we are going to screen more than 1 lakh people all across the India for urinary ACR. And this is a big project which is going to be launched by Diabetes India. And I would like to congratulate Dr. Manisha and Dr. Arvind and everybody who is part of this interest group. So all of you are going to have a big responsibility in next few months when we are going to implement this project. So I will request everyone to participate wholeheartedly in this project and get in touch with Dr. Manisha Sahay, and you can become part of this interest group for the future activities. Coming to the debate part, so I think these are not my slides. Can you check? Yeah, these are, I think, Manisha ma'am's slides. Yes, no, I have uploaded my slides. Please check the slides. So, ma'am, if you are, please, you can also say, but can you please check? Do you have my slides? I have uploaded in the morning. Okay, so I would just like to say that we have seen that with the discussion also, the SGLT2 inhibitors, they have a very, very important role to play, and as well as the GLP-1 with the evidence of the flow trial. Now the GLP-1 are also in the queue because if you're talking about the renal protection, then you cannot ignore one class and can depend entirely on one. If you can give both, then why not to give? So I wanted to show you one slide which unfortunately I'm not able to show. So you have heard about the Amar, Akbar and Anthony. So if you talk about the power of SGLT2 inhibitor, if you say they are good, they are obviously, but if you add a GLP-1 to that, then the renal protection increases. And if you add a MRA again, for example, Fineron to GLP-1 plus SGLT2 inhibitor, then renal protection increases more. So this is, I think, this is the message which I wanted to convey to this house in this debate, which unfortunately I'm not able to present because of the loss of the slides. But my message would be that SGLT2 inhibitors, definitely they are the first choice. Now we have the evidence that ma'am has already mentioned in the previous discussion that you can start even with the EGFR of 20. There is no reason to discontinue even if the EGFR declines further. But for that, all of us need to be on the same page, because my confidence will only increase if my colleagues are supporting me and they are supporting the science. Otherwise, what will happen is that what ma'am has said, if creatinine rises, oh, that doctor has started the wrong medicine on you and I'm stopping this medicine. Definitely, when you stop SGLT2 inhibitor, creatinine will come down, but again, it is not going to benefit the patient. So similarly, there is a role of GLP-1 analogs also. So if you are able to give GLP-1, so please do consider giving GLP-1 because they have a good glycemic control as well. At the same time, they are able to reduce the CV mortality and the CV risk as well. And again, the Finerenone is a very, very important drug nowadays. If you are having urine albumin, urine ACR which has increased, then probably if there is a persistent albuminuria, then this is again a very important drug to be considered. I think in this hall there was another question which was put up by Dr. Puneet Saxena, and he was asking about the urine ACR. So it is important to understand that EGFR may be stable, but urine ACR may be increasing. So urine ACR which is increasing or which is persistently there is a sign that very soon the person may be having a decline in EGFR as well. So this is something which we can take from this. So I will hand it over to Dr. Manisha ma'am. So yes.
Just say SGLT2 inhibitors, we are proponent. I am also proponent of SGLT2 inhibitors. We have recently done a real world study of 40,000 patients in our country. I am present in an endo in Boston. And the study says that the infection rates, as far as the genitourinary infections, especially the UTI, is not very common with the SGLT2 inhibitors, but it is the genital infections which are very, very common. So in some cases, we have to withdraw the SGLT2 inhibitors. That is the one point. At that point of time, I think it is the GLP-1 receptor agonist is the drug of choice, just to have the renal benefits. So that is one important point we have to discuss, the genitourinary infections. And sometimes the recurrent urinary infections, especially in women. In that case also, we have to withdraw the SGLT2 inhibitors. Yeah, yeah, it is around 20%. Post-menopausal, there is no much difference, but it is the hygiene which matters a lot. It is the hygiene which matters. If you have a good hygiene, even better the premenopausal or postmenopausal ladies, it is immaterial. So we have done that study also, the hygiene, the wearing, the underwears, and the environment, especially Manipur, and we have done all the states where the rains, too much of rains are there. So we have seen the difference between all these things. They matters a lot. So it is the awareness and education. Whenever we are prescribing SGLT2 inhibitors, if we educate or the patients well, I think that makes a good choice.
So sir, now slides are there. So I will just show 2 or 3 slides, not many slides. So this is one slide which highlights that in the majority of patients with diabetes, albuminuria happens much before the EGFR declines. So it is important to understand that albuminuria is often an earlier marker of CKD and increased CV risk than EGFR decline. So please make it a point to test for the urinary ACR in all your patients. And I think this KDIGO statement has been discussed, and this is a development. But what I wanted to show, this slide is again so this slide is very, very important. So this is talking about the combination treatment improves renal and CV prognosis in patient with type 2 diabetes. If you look at the SGLT2 inhibitors, then you will see that definitely it is 0.63 has there is an improvement in the renal outcome. Again, if you add GLP-1 alone, there is definitely a benefit. But if you have only you are adding MRAs, then you are again having a benefit. But what happens when you combine GLP-1 RA plus MRAs? There is an added benefit. When SGLT2 plus GLP, there is more added benefit. And here you can see when you have added everything, SGLT2 plus GLP-1 plus MRAs, you find that there is a maximum risk reduction which is happening. So I think the data is favors the use of all the three. Sequence, obviously, as per the current status, SGLT2 inhibitors, then if albuminuria is there, then MRAs and GLP-1 also. Thank you very much. And again, the 4 pillars which Harish talked about, these are the same 4 pillars. Thank you.
So thank you, sir. Thank you for wonderful talk. Now the last part of our this kidney disease session is future activity planning for diabetes and kidney special interest group for 2025. I would like to invite Dr. Manisha Sahay for the same. Madam, please.
Thank you. Thank you. It's a real honor to be here. And as I said in the beginning, it's a teamwork. So, see, all of us are having so many conferences. We are discussing so many things, right from biomarkers to the latest options. We are doing all that. But as I said, are we making a change? We are not able to make a change. So what's going wrong? We are doing some things. We are much better off than what we were a decade ago. But still, I think we have not reached the optimal stage. And the ones in this group are here because we want to make a difference. So I have developed an easy agenda, 10-point agenda, which as a nephrologist, I feel will work, should work, provided we work as a team. Can I have my slides? which appeared earlier, now they have disappeared. जो पहले लगाया था वो लगा दीजिए, इसके पहले लगाया था ना. हाँ, बस ठीक है. So I'll be talking about where do we go from here. And we all know that diabetic kidney disease is very important. Mine is not a theory lecture. This is the only theory slide. 17% of diabetes of all Indians have kidney disease. So we are sitting maybe 100 people. 17 of us already have kidney disease. We are not aware. And 50% of this kidney disease is because of diabetes. We all know. And 50% of all diabetics, many of us are diabetics in the room, are going to progress to diabetic kidney disease. So is it not worrisome? It's definitely worrisome. Other important thing is you are all aware of Ayushman Bharat. Now, government has analyzed the budget of Ayushman Bharat. Do you understand, do you know which is the major money consuming modality? Hemodialysis. It is the main money consuming modality, even beating oncology and cardiology. We were also surprised. And who is paying for this Ayushman Bharat dialysis management? Who is paying? All of you, taxpayers, right? 30% of our salary is already going into management of dialysis patients. We cannot deny treatment to them. They are our brothers, sisters. We can't tell we'll stop dialysis. But the thing is, we should become smart. We should try to prevent kidney disease, which none of the government schemes is covering. Neither Ayushman Bharat nor Arogyashri or anything. Do we have any preventive package for a diabetic? Nothing. And how much will a preventive package cost? 3,000 rupees a month to the government. How much is dialysis costing? 18,000 rupees per month. So are we not doing a foolish thing? We should take care of patients with dialysis, but at the same time, we should focus on prevention. So this point I want to get across. And prevention package, we have been talking about the prevention since the beginning of this symposium. So now I have suggested a 10-point agenda. What is this? First thing is, already one of the speakers covered that unlike previous times, now chronic kidney disease is included as NCD, non-communicable disease. Till now, diabetes, heart disease, AIDS and COPD were included under NCDs, but CKD was not there. So how does it make a difference? If a disease is included as NCD, then screening has to be done at the PHC level also. Now tell me how many of you are from PHCs here? So this is what is lacking. We are all working in tertiary care, or at least secondary care. None of us PHC. And whom do we need to teach all this, what we are talking about? To the PHC doctor. The doctor may be a nephrologist, unlikely. Maybe a physician, unlikely. Maybe a diabetologist, unlikely. Maybe an MBBS. But do you think he will not get educated? He will get educated. We have to give him guideline, 10 commandments. Do these 10 things on your prescription. That's it. And that is not happening as of now. So we have to give training to these departments, PHC, primary healthcare centers, because now it is included in the National Communicable Disease, Non-Communicable Disease Program. So primary care, what should be available? Creatinine. We have talked about EGFR, this, that. Is it available? Creatinine is available. Are the healthcare professionals, the MBBS people posted, they educated that they have to use EGFR tool? No. Here we are fighting about cystatin, creatinine. Creatinine is available, but nobody is doing the EGFR. Everybody has a smartphone? Yes. So this can be calculated at the PHC level. So PHC, even whatever specialty the doctor is, EGFR should be mentioned there. And if the EGFR is less than 60, refer. Urine albumin. We are discussing about the methods of doing urine albumin. But urine albumin, is it available there? No. What is available? Urine protein by dipstick. So that's there. So at least do a protein. That's not ideal. But instead of not doing anything at all, UPCR, and I told you there's a formula you can convert to UACR. It's not ideal. If UACR is there, excellent. But most of the places, it's not there, and even protein is not done. And many of the times, we forget the urine examination. We look at creatinine, urea, electrolytes, calcium, phosphorus, everything. But urine examination is forgotten. And if 1 plus protein is there, we neglect it, thinking that it's not important. But that's important, and that should be taught by this group by giving a guideline document to the primary healthcare worker through the policy maker. So this group informs the policy maker, hands the document. We prepared the document, 10-point agenda to the PHC. So this is what I said about the screening toolkit, at least a dipstick and a creatinine. If the government allows, we suggest including an albumin there. So this should happen. This I already said, guideline document. So guideline document, These 10 things you should write in your prescription to that person. Write ACE or ARB, write BP medicine, metformin, write SGLT. To this we should tell 1, 2, 3, 4, 5 steps. So this is the package which we need to get included in Ayushman Bharat. It's not there. India is the only country where we have SGLT2 available in generic forms. America doesn't use so much of SGLT2 like we do. We are in fact much better off than Western world. We have generics. Indian pharma is good. We don't produce our own medicines obviously because we are a resource limited country. New drug needs 3 billion US dollars. No problem. Our people, they do not reinvent the wheel. They take it from the Western world and make biosimilars which act well. So I think this package is quite easy to make, 3,000 rupees per month for the government of India. So this we should tell the government. And there are many big people in Diabetes India whose only work should be to inform this to the government of India. Then prescription audit. So who should do this prescription audit? So people will get angry. Doctors will get angry. How dare this person audit my prescription? But I think it's needed. Who should audit? First, you yourself audit. When the patient is going out from your clinic, just check it in your mind. So what 10 commandments have you written about the diet? Did you write about sleep? Did you write about smoking? Did you write metformin? Did you add SGLT2? Have you added RAS blockade? Have you added statin? Remember statin for all diabetic kidney disease, even if the cholesterol is normal, even if the lipids are normal. Have you added bicarbonate? Bicarbonate should be around 18. Have you added that? Vaccination. So there are simple 10 commandments which I'll be talking about tomorrow, should be there in the prescription. Audit yourself before somebody else audits you. Now, as a part of legal system of Telangana, we are getting complaints from patients that this doctor has not started this drug. Do you want to fall in that soup? No. So for patients' benefit, country's benefit, audit your own prescription before somebody else audits it. Then patient advocacy groups. So we have a kidney warrior group and there are no people from kidney warrior group in diabetes conferences. They were not there in nephro conferences also. And in India, we do not talk to them, patient advocacy groups. It's important because the policy makers, government may not listen to you. They will listen to the patient support group. They will listen to the patient. Patient is a strong proponent. I'm dying. If the patient says, government listens. So that's very important. Patient advocate groups. Patient awareness. Tell the patient. On public media, World Kidney Day, through celebrities, tell the patient, if you're a diabetic, did you check your kidney? That's it. If that is done, patient himself or herself will demand from his doctor, doctor, you have not written a kidney test. That itself is important. Demand generation. Patient should demand. That is 7th point on the kidney agenda. Power of media. This we all know. Do the policymakers listen to us? They may not. They still listen to the patients. And if something comes in media, media is a watchdog for the government and we should utilize, strategize and use the media to our advantage. Now see, this happened on 12th February, Power of Media, where the Indian cricket team talked about organ donation and you can see there were 17,000 organ pledges since the start of the match to the end of the match. Can you have that impact? Can a single doctor working anywhere? No. So cricket, use cricket for your own advantage. So now they are promoting organ donation. One word, if you have diabetes, check your kidney, check urine, check creatinine. Enough, that's it. So that's important. Utilize the media. Diabetic research grants, Diabetes India is doing a good job and we ask for research from different people as well as develop some research questions ourselves and do multi-centric studies and write to ICMR. So we are in the process of writing a project to ICMR, probably with team of Diabetes India. From a huge organization, it's likely to get sanctioned for doing the studies which the previous speaker was talking about. And social media, that's another powerful tool. It can be used to educate the patient. Many of the patients are on Facebook, they are on Twitter, X you call it now. So I think that's very important. So these are the 10 methods by which all of us sitting in this room can make an impact on diabetic kidney disease in our country. What I said is very important. All of us are educated enough. We are discussing molecular level. Yes, this group should continue to do that. But what should be the focus? Why are we all collecting here? To prevent diabetic kidney disease before it swallows all of us, before it swallows the budget of India. Remember, same thing has happened in the Western world and now they are talking about palliative care. They are deciding which patients not to give dialysis. We'll also end up like that. Government has given us 50 dialysis machines in our unit. We are doing 5,000 dialysis per month and still patients are waiting. So this is not the way how we are treating patients. We are treating them when we identify them late. We have to screen them early and focus more on prevention. And from next time, we should make sure that we get the doctors from PHC, or these doctors become trainers themselves and train the doctors in their PHC. So develop a hub and spoke model. The purpose of is not to sit here and enrich ourselves. Purpose is to go back from this area, go to your own area and become the hub center, whatever your specialty is, and educate the PHCs. If you do that, if we do that, nobody can stop you from getting a Nobel Prize also, because that's what this country needs. So thank you very much for patient hearing.